Do you restage patients, and if so, when do you do that?
Yeah, like as I alluded, like I think those models that we use had not been looked at really as dynamic models that you can use them. So it's very difficult to apply them, but I think there is still some common sense. Like if somebody had low blast originally and the blasts are increasing or acquired new mutations, further cytopenias, I think they're not going to do well. One issue is like, unfortunately, many of the studies sometimes would still require the IPSS as inclusion criteria for the study, eligibility criteria. And for example, after hypomethylating agents failure, that doesn't stand. Like, and I think we've done work together. Aziz from Cleveland Clinic had led that we showed that neither the IPSS or the revised IPSS really predicts outcome after HMA failure. And yet we still do it for every study. There are different models of looking at it. But I think what makes common sense is still, like, again, if you see change in count, increased blast, new cytogenetic abnormalities, that will make a difference. Sometimes when patients change, especially if I saw a clinical pattern in the change, I think it's reasonable to recheck, for somatic mutations, because every now and then we'll see patients acquired new mutations that could be targeted. So somebody became proliferative, suddenly the count is high. It's rare, but you may acquire a FLT3 mutation. You could acquire an IDH1, IDH2 mutations, things that are nowadays could be potentially actionable and targetable. So there is really no good restaging system. I usually, if patients are doing well, I don't repeat regular, frequent bone marrows. Even you could make argument if somebody is not going to transplant and you started them, for example, on hypomethylating agents and they have hematological improvement, you really don't need to repeat a bone marrow unless you see clear failure of the treatment by dropping the counts later on.
I totally agree. I don't have a set point where I would stage patients. However, I will do it if I feel like the results might influence my decision as to how to treat this individual patients. For example, if someone becomes cytopenic, they're not recovering in time for their next cycle of therapy, I might stage to see if this is disease progression or if this is drug-related cytopenias, or perhaps people may need to have their cycles extended a little bit, or if I, as you said, think that there may be progression. So there's no set time.
Yeah, it seems like we really tend to do it based on a patient's blood counts, appearance of blasts. There are usually pretty clear clues that somebody is starting to progress. And as we move forward with prognostic scoring systems, where we even have examples of using machine learning, artificial intelligence to incorporate all of the many factors that go into prognosis for a person, from all the molecular abnormalities and their interaction and hierarchy to clinical characteristics. And I think that in the future we're going to have to go to an online, some kind of app, enter a lot of information in real time about a patient, and then have an output about prognosis.
I'm glad that you mentioned artificial intelligence. I think the most interesting session that I went to at ASH was the artificial intelligence session that was yesterday, where Kungsang Yu from Harvard actually presented one of the most beautiful overviews of what the use of AI is going to be, I think. And he was even able to show that morphologically, machine learning could actually pick up P53 mutated cells and was able to fit the curve just to the P53 mutated patients, what their outcome would be with the morphological data with machine learning. And I think that as we start to incorporate the complexity of this disease, that as he said at the end of his presentation, physicians will not be replaced by AI, but physicians who are able to intelligently use AI will replace those physicians who are not able to use it. So I think that we are entering one of the most exciting phases of medicine. I probably won't live long enough to see the full outcome of this, but that we're really going to enter a phase where we're able to use machine learning to better stratify these patients right off the bat to how they should be treated. And it's very exciting, I think.
Oh, come on, you'll be one of those people with the 25-year-old muscles forever.
I'm working, I mean, I'm trying, but I don't know about that.